A patient I think about often used to camp very close to where we would park the RV regularly. And it used to be kind of like tucked up under the bridge, but sometimes it would come a little bit closer down. And if he was ever, on the street, I would always ask, is it okay if we could park here? We parked there every other week, but no matter what, always ask his permission because if he was close by. And he would say, okay, that's fine, but didn't engage with us for like the first couple of months. And then eventually would come up and get some supplies, some things, and kind of started talking to us. And after a couple more weeks, months of that, he was like, I'll see the doctor and get some testing, and got tested. And he had already known he had hepatitis C, and he had expressed that was his main priority. I was like, what? He did have a substance use disorder. He did have a severe mental health condition, but that was like the main thing that he wanted treatment with and he wanted help with. And our team was able to treat his hepatitis C. We talked and I was like, can you take these pills every day for this amount of time? He's like, I absolutely can. And I was like, all right, well, let's do this. And he did. And the only pill he missed was one pill, is because he accidentally took it twice on the same day. And he has successfully treated his hepatitis C. But during that, he came back, every other week. He saw us all the time. He met with the other community health workers teams there. He met with other folks and eventually ended up getting into housing and then got into see psychiatry and get care for his mental health conditions and got on medications that helped him feel better. Those are the stories that matter. So sometimes mental health is first, sometimes it's third. And it's just like figuring out like what is important to patients and going with them on their journey to help achieve those goals and then see if we can help connect them to other places.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana. Welcome back to EM Pulse. Part of our goal at EM Pulse is to look at the innovative aspects of emergency medicine. Ask, how are we doing this well? What can we all adopt to be even better? One of the parts I love about my job is hearing how others are identifying barriers to health and figuring out how to overcome those barriers. Our family medicine colleague, MK, is one of those innovators who's thinking outside of the box in this case, out of the box known as our hospital. She is part of Wellness Without Walls, a mobile unit that delivers clinical services like HIV, sexual health, and even broader services and referrals to unhoused communities and transitional aged youth. We hope that as you hear this interview, you can be inspired to think of ways to use your own hospital resources to better serve your own unhoused community. So today, I am here with my colleague, Dr. M.K. Orsulak. She is an assistant professor of family medicine at UC Davis. Welcome, M.K.
Hi, thank you for having me.
Yeah, I am really excited to learn a little bit more. Tell me, what is Wellness Without Walls? By the way, I like the name.
Yes, I cannot take credit for that. It is a great name, and it does describe the program. Generally, the goal is to provide care to people outside, like you said, of the walls of the healthcare system. And Wellness Without Walls is a program that was created with that mindset in mind. So you all work in the hospital. I'm a family medicine doctor. I work there sometimes, but mostly in the clinical setting. And we see patients who just have difficulty accessing primary care services and preventative health services. And the Wellness Without Walls program was created to address that gap, to be able to bring healthcare services to meet people where they're at. And so it's kind of a hybrid between a mobile medicine and a street medicine program. Mobile medicine and street medicine kind of exist on a continuum. Street medicine, those programs, people are bringing backpacks directly into kind of encampments or spaces where people are living, going kind of door to door and meeting folks. Mobile medicine programs usually are based in some type of van or some type of RV that are driving and usually parking and staying stationary. A lot of times people are coming to them. I say that we're a hybrid because we park our van. Sometimes we're at shelters and tiny homes and spaces like that. And sometimes we are parked under bridges, in encampments, in parks. And people are coming to us, but we are also going out to them. And so this program, Wellness Without Walls, is a mobile medical RV that is a partnership between the Sacramento County Primary Care and Public Health Divisions of Health and the UC Davis School of Nursing and our family medicine department. that provides care to folks who are living outside or in shelters.
I love that. Okay, so summary, street medicine is backpacks and mobile medicine is car doors.
Yes, exactly. That is it, And there's there's hybrids all between.
Yes.
In general, they're under the umbrella of like field medicine, but also just like the idea of just going to the people.
Yeah. And why was this program created? I mean, okay, all right, that feels like a stupid question because I work in an emergency department and I can imagine many reasons why. But I want to hear from you, MK. Why was this program actually created?
Oh, like you said, you're in the emergency department. I'm in a primary care clinic. And we kept seeing people. Our healthcare system continuously sees folks who just have difficulty accessing traditional healthcare mechanisms. And so I'll start with, what I know best. But if you think about trying to get someone connected into primary care, you have to, as a patient, know who your primary care doctor is, which is hard.
Yeah.
You have to have insurance, have some kind of health insurance usually, be able to access your primary care doctor. You have to be able to make that appointment time, remember when it is, get transportation there. If you have animals and you're living outside, find care for your animals. If you have things and belongings, you have to find someone to watch that stuff. And also not to mention all the external factors that are out of your control, like weather or whether or not your encampment is displaced. Like there are just layers upon layers of barrier upon barrier into getting people who are living outside and experiencing homelessness into primary care settings. So this program was created to help reduce some of those barriers and bring a mobile clinic out to where people are that is, walk up, we see everybody who comes to us and try to provide the most comprehensive services we can.
MK, tell me about what a typical day looks like, okay? So you start at like 7 a.m., walk us through, kind of give us the picture of what your day looks like. I'm assuming it's not like my day every day.
Are any of your days the same? I feel like.
Nope. Yeah. Which is why I love
it. Well, neither are mine, but they are usually in the same time. So our clinic, I go out on the same day every week. I do a half day and we all meet together, our team. We have a wonderful, wonderful team of Sacramento County staff and lots of different roles, which we'll talk about more later. So our team, we meet at our clinic. So the Sacramento County Health Center, which is a federally qualified health center. We pack up the van and then our program is designed that we have a calendar and we go to the same sites on a regular schedule. And so I go to the same 3 sites every month on a rotating schedule. So one site I go to every other week, and then I go to one park and another park on the other weeks after that. The design, kind of like we were talking about with street medicine versus mobile medicine, those program designs can go different ways. Some people are following the people and going like with them to encampment. We chose to do a scheduled, stationary, consistent type of program for a couple different reasons, but really just to have that consistency so people know where to find us. We park the van at the encampment or under the bridge or at the park. And, one of these spots I've been going to for, 3.5 years now, the same spot every other Tuesday morning. And it's been really powerful to build up a panel there. I have a panel of primary care patients there and have met some really incredible patients there. And so we set up, we open our doors. We have some medical assistants. We have some communicable disease investigators from public health who do rapid HIV, rapid syphilis, rapid hepatitis C testing, gonorrhea and chlamydia testing. And then usually some learners. We are academic from here. Part of the role I see for me is to train the next generation of people who are providing care as street medicine and mobile medicine providers. And so we will open the doors and just see what happens.
So no appointments.
No appointments.
Open the doors. Do you call out hey, Ollie, all come free and people come? Or how do they come and find you?
Yeah. So the reason why we kind of pick these initial spots is that we partner with a community-based organization, Community Health Works. They are a really great organization in Sacramento County. And they do, office hours at some of these spots. And so people know that they are there and doing a lot of great things and just helping people connect into housing, connect into get enrolled for Medi-Cal, get their IDs, et cetera. So they do these office hours and we are co-locating our services with them. So that way people can both get some medical services, they can get some community health work and social services, and some other organizations are also there at times. For us, part of our goal is not just to provide medicine and testing, it is to provide survival supplies and things that people need. And so our team will order kind of survival supplies. So right now, it was raining a lot yesterday here. And so on Tuesday when I was there, I was, one, making sure that everybody knew it was going to rain and it was going to be cold, but providing emergency blankets, beanies, hats. We sometimes have, solar phone chargers, chapstick, sunscreen in the summer, flip-flops, the things that people need to make their life just a little bit easier when navigating these elements. And so we start there, and anybody who comes can get some of these survival supplies. And if they would also like to see a doctor, we're there.
And do they come with kind of urgent care type of complaints, or are you doing regular well checks and, checking blood pressure and, talking about diabetes and all of those things as well?
Yeah. I mean, it is a true family medicine clinic. It is a little bit of everything. And so some of it is urgent care, some of it is wound care, some of it is counseling related to blood pressure, diabetes, congestive heart failure, COPD. I also work in our addiction medicine division. So, we're intentionally talking to people regularly about substance use and the tools that we now have and the medications we have and the resources we have if they're interested in changing those behaviors in whatever way it may be. We partner with our behavioral health team to get people connected into behavioral health services. So in general, I think the goal of this program is to provide compassionate, easy to access care that can help people get into what they need, whatever that may be.
What about medications? Okay, because a lot of these things involve supplies like wound care, washing that out, new bandages, fresh, clean, all of that stuff, and also medications. How do you dispense that, or how does that work?
Yeah, so a little bit of both. Our county pharmacy and our pharmacist has been an excellent partner. And so we have a small bag of physician dispensed medications that are prepackaged. And so they are the things that we are using most often. Most of them are antibiotics. For example, we'll have a course of doxycycline, et cetera. We do a lot of testing for sexually transmitted infections, syphilis, gonorrhea, and chlamydia. So we have all the antibiotics to treat those, including bicillin. There's not a shortage. And then when it is, we have 28 days of doxycycline. So those things I'm able to dispense from our supply of medicines. It is, of course, limited in that space. Most of our patients have Medi-Cal or have access to insurance. And what is nice is that we can send in prescriptions for folks and then work with either pharmacies to deliver out to where they're staying or deliver somewhere close by or work with other members of the people in their circle to help get them medications if it's something outside of our scope.
I would imagine that mental health is a fairly large component of the unhomed population's medical issues that they have to deal with. Tell me a little bit more about the resources that you have, and is that something that you manage? Do you manage their mental health medications, or are you then making referrals and getting help for them in other ways?
Yeah, absolutely. I think it parallels my approach in primary care. I mean, a lot of family medicine is being a first point of contact and knowing what I can do for someone and then knowing when they need more than what I can do. And
sounds like emergency medicine also.
Exactly, right. So it's similar to that. Some patients I'm seeing one time. Some people I'm seeing, every other week, which is more continuity than I have often in my regular panel. And so there's a lot of different factors that play into kind of the approach. Generally, treating mild to moderate depression, anxiety is certainly within the scope of us in primary care and something that we do manage for people. If people need access to higher levels of care, we will do everything we can to help get them into those programs. And so it is a little bit of both there. We work pretty closely with our behavioral health team and their outreach team, and they will help connect people into services and into the behavioral health county services. I think a lot of it is more so about just being a point of contact and being able to have time. I think in primary care, and I'm sure also in emergency medicine, y'all feel this too, we just don't have enough time with people a lot of times. In a 20-minute visit, the face-to-face time I get with folks is sometimes so limited. And one of the wonderful things about Wellness Without Walls is sometimes when people need more time, I can give them more time. And sometimes that means listening to someone's trauma that they have experienced living outside for a very long time. We do everything in our power to see everyone who is there, and we're very, very good at seeing all the people who show up. And it is so impactful to just be able to listen to folks I think that is like the main mental health component, is just like creating a space where people can talk about what they're feeling and like create that trust, and then working with them to build it back up. Sometimes that looks like listening. And sometimes, we see a lot of folks with severe mental health conditions, substance use disorders, but that's like not their priority at the time. And so my approach is to, start with what the patients are asking and what their priorities are. Meeting them where they're at, which is a common phrase in the harm reduction land and also in street medicine and mobile medicine. That means like, we are going out to where they are living, but also like meeting them where their goals are. And so told that story at the beginning about someone who came in for hepatitis C treatment who ended up getting connected into mental health care services. And that's kind of the goal, is just building that bridge and getting people into the treatment when they're ready.
I love that. MK, meeting people where they're at, especially when they're struggling with all of these issues, sometimes can feel unsafe or can feel uncomfortable. Can you talk to us a little bit about how you feel as far as your safety, your own staff and your own personal safety is in those settings?
I think for safety, it's been something that, we certainly work on. We have our policies, we have our team, we have our approach. But generally, like when we have been out providing care, there's been nothing but openness and accepting, or like sometimes ignoring, but not as much as a conversation. What I see more often is people being like, oh, you're here? Let me go get my buddy. They need, and like kind of more of that connection. Oftentimes people who have experienced traumatic events can respond in a lot of different ways, but we are very aware that we are like in their homes and in their spaces and try to approach our clinic shift and our time there in that way. I feel like I have a wonderful team. I feel like the patients we see are all wonderful and open. And I think about safety, but I think about it in the same way I do like when I'm in my primary care clinic or in the hospital.
Yeah, that's fantastic. Yeah. So it's like your approach to safety is prevention by using dignity and humility as you approach into this space. Is that fair to say?
100%.
Okay, this sounds pricey. You got a lot of people, and not a 20-minute time slot process. How is this program funded and sustained?
Yeah, and I think you're touching on like one of the key points of the future of street medicine and mobile medicine is sustainability. Our program specifically, our Sacramento County team from primary health and public health did a lot of work and got a HRSA grant that funded the initial mobile unit, some CDC grant funding as well that supported some of the beginning of this program, and some of that grant funding supports the operations now. Also, we are a satellite of our FQHC. And so there's a lot of different models. Some are, standalone street medicine programs, standalone mobile, volunteer-based, et cetera. Our program specifically is a satellite of our FQHC. So there is structure to see patients who are insured and seeing those patients and getting some reimbursement for those visits.
So it's a combination, it sounds like, of grants, probably some institutional buy-in, both local, county, and your own institution, some generosity of time there, and also asking funders or insurance companies to pay for the visits. Is that fair?
That is fair.
So
yes.
You must have an EMR and are doing documentation and like tracking these patients. Is that also fair?
Absolutely. Yeah. It is in the same EMR that I use for my primary care clinic at the FQHC. So exactly like we would like a regular visit. I order the labs I can the same way. Another question that comes up when this topic comes up is about like referrals. That historically has been one of the biggest barriers. And, as a primary care doctor, that is part of my role, is getting people connected into care, like higher levels of care when they need it. But patients can only be referred to specialty care from their primary care doctor. So oftentimes, if people are walking up, and I'm thinking specifically of this person who had a broken arm who needed to get back into ortho, and it was a journey to get them there, it requires connecting them with the primary care, getting an urgent appointment, getting them into the primary care, getting transportation there, getting them into that visit, making sure they get to that visit, getting the referral, making sure that they know when the referral is processed, because usually like when referrals are processed and approved, they'll call the patient back, but sometimes people's phones aren't working, making sure that they know their referral is processed, then calling to schedule an appointment to follow up. So there's so many ways that can go wrong.
Yeah.
And there was actually some big advocacy throughout the state to change that. And there recently has been some work to try to advocate for and move to allowing street medicine and mobile medicine providers, field medicine providers, to be able to provide referrals directly for patients to help address that gap.
Tell me a little bit about impact, why should this be a thing that institutions and counties and providers invest in? Like, how are you guys changing the landscape of health for our unhomed population?
Yeah, I mean, I think people should care because people deserve access to healthcare.
Okay, fair enough. Give me some hard numbers here, MK. Because you're a human being? All right, fair enough. Good point. Good point.
But, my initial response to that is wherever you are, see if there's a mobile medicine or street medicine team close to you and see if you can go out with them for a day. And then look at the impact you're having. Like, see it with your eyes about the impact you have on people's lives. Just the act of bringing services to people and bringing healthcare to people, conversation that you're able to have, the trust you're able to build, it's just unlike other points of access at times in our healthcare system. And so, I am speaking to a lot of emergency medicine folks, and you'll see this every day. I mean, there's people who need connection to primary care. They need preventative care. Like, our healthcare infrastructure that is not within the scope of emergency medicine, it's just things you can't do. Like, you can't do longitudinal behavioral health care to the caliber that sometimes it needs to be in the emergency medicine department. I always appreciate you as emergency medicine colleagues for this. You are the front lines. Like, you are the door that is always open. This is a way to help get people from that door into maybe the door that fits them a little bit better, or can fit their needs a little bit better, and can help them get the care that they deserve, with the goal to get into stability, get into housing. And it takes continuous investment and trust building and bridge building to build that. And that's what these kind of programs are. There's literature out there that does show that these mobile medicine programs, street medicine programs are improving outcomes. They're improving preventative care. Part of our team comes from our sexual health promotion unit. And, we do a lot of testing, and I think 10% of our patients have a test positive for syphilis, which is
oh my God.
And so we're able to get them connected to care, get them treated. We treat them there. If they need 3 shots, our communicable disease investigators will get them into the clinic, or they can come back and see us next week. That is one example of just kind of how these programs can provide that continuity that is outside of the hospital, the emergency room.
Yeah, I love that. Okay, let's say that you have lighted up a light bulb, flipped the switch in some listener. What would be your advice for them on how to approach this, how to start a street or mobile medicine program, either one? Yeah,
it is really one of the most powerful and meaningful parts of my job. And so why not say keep that light bulb lit, follow it and reach out. There's a lot of people experiencing homelessness in California, across the nation, but also in California. And there are a lot of programs, and they keep on growing and growing. So I'd say just look and see what some of the closest programs are to you, and see if you can connect with them, and just go out with them for a day to see what it's like. If you're interested in learning more, there is the California Street Medicine Collaborative, which is the statewide street medicine collaborative. That is a wonderful, wonderful group of people. And I want to take this time to say thank you to a lot of them, because they have helped me and us and our program develop and get better. Yeah, that cohort of hundreds of folks there now. We have monthly meetings. People are welcome. You can look online, and it is a great kind of access point. And it also is a good access point to learn about kind of the landscape, not just the medicine part, but what's happening with homelessness and healthcare in our state. Nationally, there's the National Healthcare for the Homeless Council, which does a lot of webinars and kind of continuous information sessions to learn more about how to provide better care for folks living outside and experiencing homelessness. So that's kind of a national organization.
Yeah, that sounds great. Okay, where do you see the future of street/field medicine in the next 5 years? How do you imagine it evolving?
That's always a good question, because my first thought is ideally the goal is to have access to healthcare and access to housing, right? And so street medicine is a piece of that puzzle, and we're providing care to folks when they're living outside, but also continuing to advocate and promote housing solutions and solutions that allow people to have safety in a home is key. For the field of street medicine and mobile medicine, I think we've seen it expand so much, and there's been a lot of growth and advocacy in our state of California that has led to great advances. So some of it is from changing or adding billing codes so visits that are on the street can be visits technically. And that was like a key piece that needed to be done. And so, appreciate all the folks who did that work and talking to healthcare administrations to advocate for that. And like we kind of touched on earlier, funding is going to be a continuous issue. So being able to come together as people providing care to folks outside and showing that these programs are working and that investing in them is important, and also that they're different than a primary care setting. I talked a little bit earlier, like I need more time with people. I can't do all the things that need to be done with folks in a 20-minute setting. And so thinking about reimbursement streams and things like that is going to be a key part, I think, to the sustainability of street medicine. And what is exciting is that even just in the last 3 to 4 years of when I've been a part of this program, the solidarity and the growth and the providers, that is the future. I think building with each other and building the programs with each other to be able to not do this alone. And I think, I'm here. I feel like building the bridge with the emergency departments, figuring out like how to provide better care for folks. I'll briefly talk about a program that I am working on within our healthcare system, the UC Davis Street Medicine Consult Service. And so this is based on a program that was piloted by some colleagues down in Southern California. The goal is to identify the folks who are coming into the emergency department and being admitted who are sick with things like COPD, CHF, some of those chronic medical conditions who are not getting primary care access because they're all coming into the emergency department. So similar to like another consultant service, you all could consult our street medicine team. We would see the person and then follow up with them at their encampment to be like, did you get your inhalers? Are you still getting your inhalers? How is your weight doing? Are you taking your Lasix? Do we need labs? It's pretty much, discharge follow-up for people who are experiencing homelessness. And so that is a program that we are working on in our health system now that just launched. So just started this pilot this month. Actually.
Wow.
So,
Congratulations.
Yeah, thank you. And so looking forward to seeing how that can provide care to the people I think we're missing, the people who are in the hospital who are not making it out of their tent to walk to the mobile clinic because they're too sick, Yeah. And so I think some of these innovative programs are exciting.
Yeah, that's super exciting. And it's another way of, like you said, meeting people where they are throughout this process. Anything else you think that we should know?
When talking about caring for people experiencing homelessness, there's a lot of great organizations who are doing the work. And also, don't forget to talk to people who are experiencing homelessness when designing these programs and designing like what people need. I think about this a lot with the patient who I talked about at the beginning. There was 4 or 5 other medical problems I would have prioritized probably in that acute moment. But what that person wanted is what they knew they needed and got them plugged back into care. And when thinking about, things like where should we do outreach to like what kind of supplies would you all like? Like these are questions we're talking about with people all the time. And so don't forget to include the voices of the folks who are going to be using the program and to value those when building your program.
That's such a great point. Okay, this sums up our episode on mobile medicine, field medicine, street medicine, all of those things. Keep listening to hear more innovative ways to reach our patients outside of the emergency department and hopefully improve the health of our patients coming into the ED and getting them access in the right way at the right time. Thank you to our department for supporting these types of efforts. Thank you to OM Productions for meeting our production needs. Until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.